Good day, everyone. Let me take this opportunity to congratulate everyone for making it this far. This is, of course, one of the very few steps that you need to take before you get this card, hopefully with your name on it and your nice picture there. So this is it. This is you right now. And these are the topics to study for the board exams. My topic is just this little chip over here. So my first tip to you is just to concentrate on these other topics. Read the book. Hopefully, if you took your internship seriously and listened to my talk today, you'll be fine. I certainly hope so. So the trick is just to know the must-know cardiovascular topics, which consist of the following: the cardiac cycle, the cardiac anatomy and physiology, history and physical exam. Hopefully you took this up during your anatomy and physiology. And of course, we'll go straight to the clinical problems in cardiology that consists of the following: hypertension, coronary artery disease, heart failure, discussions on cardiac drugs, hopefully which you took in your pharmacology, and of course miscellaneous topics like valvular disease caused by rheumatic heart disease. So in the next couple of minutes, this will be the outline for the review. We'll deal mostly with multiple choice questions. There are a couple of true or false questions just to test your analytical mind. Of course, there are no true or false questions in the board exams. I'm going to give you high-yield flashcards and, of course, short discussions on the different topics, focusing on the following, which I consider must-know and high-yield in the board exams. Let's start with the first high-yield flashcard, and this is on epidemiology. The #1 cause of mortality in the Philippines, according to last DOH statistics, is, yes, you guessed it right, it's heart disease. Now, we all know that, but do you know what the #2 cause of mortality would be? It's vascular disease. Aha! Let's review anatomy. The mitral and tricuspid valves are also known as the atrioventricular valves. The aortic and pulmonic valves are also known as the, I hope you get to answer with me, yes, these are your semilunar valves. More review. Physiology. During systole, the mitral and tricuspid valves, yes, they close. During diastole, the mitral and tricuspid valves open. Finally, during systole, the aortic and pulmonic valves, of course, they open, which means you need to be familiar with your cardiac cycle. Let's go now to a multiple choice question. Which one of the following happens during ventricular diastole? Is it A, B, C, or D? Now, during ventricular diastole, this is the time that the mitral valves and tricuspid valves open, and then there's a sudden gush of blood going from the atrium into the ventricles. The answer here is, of course, your isovolumetric relaxation, and this forms the first part of your ventricular diastole. If you review your cardiac cycle, of course, you have two phases, which are your systole and your diastole. During systole, the processes that occur consist of isovolumic contraction, followed by maximal ejection, brought about by left ventricular contraction. During diastole, this is the phase of left ventricular relaxation, consisting of the following phases: isovolumic relaxation, the start of relaxation and reduced ejection, and of course the last phase is your atrial kick or atrial systole. Reviewing again the cardiac cycle, during systole, ventricles contract, and your left ventricle and right ventricle pump blood to the systemic and pulmonary circulation. In relation to your heart sounds, your systole occurs after your first heart sound. Diastole consists of ventricular relaxation, wherein the ventricles are filled with blood. and blood flows from the atrium to the ventricle. In relation to the heart sounds, diastole occurs after the second heart sound. If you still recall, S1, S2, S1. The distance or the phase between S1 and S2 is your systole, while that phase of the cardiac cycle after S2 and before S1 is diastole. Take note that in a normal heart rate, systole is always shorter than diastole. But during episodes of tachycardia, it is the diastole that shortens. Systole remains the same. Of course, not to confuse you with the Weger cycle, but this is something that you need to be familiar with. This is just to highlight the relation of your cardiac cycle or your hemodynamics to your ECG. If you recall, the QRS complex in your ECG reflects ventricular depolarization. And this ventricular depolarization is the one that leads to ventricular contraction. That leads to systole. And of course, take note that your S1 basically occurs after your QRS complex and at the onset of ventricular contraction. Your S2, on the other hand, in relation to your ECG, occurs after your T wave because your S2 heralds the start of your ventricular diastole. So just a review of your ECG waveforms. The P wave reflects atrial depolarization. The QRS reflects ventricular depolarization, while the T wave reflects ventricular repolarization. A brief review of your circulation. Of course, when the ventricles contract, you pump blood into the aorta, and this is oxygenated blood that goes to the different parts of the body and returns via the venous return to the vena cava, both the superior and the inferior vena cava, going to the right atrium, the right ventricle, into the pulmonary artery for the blood to be oxygenated in the lungs, and goes back through the pulmonary veins to the left atrium and repeating the cycle. Let's go to another question. Which of the following pathologies gives a diastolic murmur? A. Mitral regurgitation. B. VSD. C. Aortic stenosis. D. Mitral stenosis. The answer here is mitral stenosis. And in order to understand that, you need to, of course, be familiar as to what would be the position of the valves during specific states of the cardiac cycle. For example, systolic murmurs that occur in the apex, specifically the mitral area. Try to imagine what the mitral valve would be during systole. During systole, the mitral valve should be closed because that's the time that the aortic valve should open in order to allow ejection of blood into the systemic circulation. But if you hear a murmur during systole at the mitral valve, that means there's a leak in the mitral valve, and that corresponds to mitral regurgitation. And MR presents with a hollow systolic blowing murmur. What about the tricuspid area? You hear a systolic murmur in the tricuspid area. What should the tricuspid valve be during systole? Yes, like the mitral valve, it should be closed. But if you hear a murmur, then it corresponds to tricuspid regurgitation. This also presents with a hollow systolic blowing murmur. Let's go now to a base. Systolic murmur at the base, specifically your aortic area. Imagine what the aortic valve would be during systole. Yes, it has to open during systole. But if you hear a murmur during systole in the aortic valve, then it means there's something obstructing that particular valve, and that is brought about by aortic stenosis. AS murmur presents with a crescendo, decrescendo murmur at the aortic area. Same thing with the pulmonic valve. A systolic murmur heard at the pulmonic valve corresponds to pulmonic stenosis. The other systolic murmur that you can also hear, which is best heard at the third left intercostal space mid-clavicular line, is the holosystolic blowing murmur of a ventricular septal defect. Moving over to diastolic murmurs, at the apex, mitral area, imagine what the mitral valve should be during diastole. It should be open. And since you hear a diastolic murmur, then this murmur must correspond to a mitral stenosis. And a mitral stenosis leads to a diastolic rumbling murmur. That's the classic textbook description of MS. On the other hand, tricuspid area, when you hear a murmur during diastole, corresponds to tricuspid stenosis, which is less common compared to MS. Moving over to the base, at the aortic area, you hear a diastolic murmur, and imagine what the aortic valve should be during diastole. Yes, it should be closed, but because you hear a murmur, then this corresponds to a leak, and this reflects aortic regurgitation. AR typically presents with a decrescendo diastolic murmur. Same thing in the pulmonic area. You hear a diastolic murmur, and that reflects pulmonic regurgitation. Let's move over to physical examination of the heart. If you recall from your Medicine 1, it consists of 3 parts: inspection, palpation, auscultation. So not much on percussion for the cardiovascular exam. Multiple choice question. In the examination of the precordium, the presence of one visible precordial pulsation is termed A. Dynamic precordium, B. Adynamic precordium, C. Hyperdynamic, or D. Bulging precordium. So if you have one visible precordial pulsation, this is defined as dynamic precordium. A patient presents with a diffuse and sustained apex beat at the 6th left intercostal space, anterior axillary line. Which of the following is true regarding this finding? Does the patient have LV dilatation? Is this LV hypertrophy? Is it a combination of the two, dilatation and hypertrophy? Or is this biventricular hypertrophy? If you recall, if you have a diffuse and sustained apex beat, this reflects left ventricular hypertrophy. On the other hand, a displaced apex beat laterally and downwards to the 6th left intercostal space anterior axillary line reflects left ventricular dilatation. Therefore, this finding is consistent with a combination of left ventricular dilatation and hypertrophy. In the inspection of the precordium, 0 pulsation reflects adynamic precordium. When you see one visible precordial pulsation, you term it dynamic. And finally, 2 or more visible pulsations is termed hyperdynamic. Let's move over to a high-yield flashcard. Palpable vibrations due to high velocity flow across the cardiac valves, best felt by the ball of the hands, are called, this is easy, so vibrations that are palpable, felt by the ball of the hands, these are known as thrills. Okay? Review the parts of your hands that you use for palpation. This is your heel, that's your ball, and those are your tips. The tips are used to palpate localized pulsations, while the ball is used for thrills, and finally the heel is used for palpating heaves. So what are the parts of the heart that lead to heaves and lifts? Heaves reflect hypertrophy of a chamber, while lifts reflect dilatation of a particular chamber, usually an upper chamber. So in your physical examination, you can feel a lift at the 2nd right intercostal space. parasternal line, which reflects the aortic area. On the other hand, a lift that you feel on the opposite side, the second left intercostal space parasternal line, is consistent with a pulmonary artery lift. An additional lift that is felt at the third left intercostal space, just below the second, can also be reflective of a lift caused by the left atrium. The right ventricle will cause a pulsation or a heave, usually at the left parasternal area and sometimes extending to the epigastric area. And this is caused by right ventricular hypertrophy. And finally, when you feel a heave at the fifth left intercostal space, mid-clavicular line or beyond that, and that reflects the left ventricle consistent with a left ventricular heave. So when you feel a lift at the aortic area, this reflects a dilated aorta, which you can commonly see in hypertensive patients and sometimes in patients with an aortic aneurysm. An LA lift seen or felt at the third left intercostal space reflects also a dilated left atrium, while a PA lift on the opposite side, the second left intercostal space parasternal area, reflects or is secondary to a dilated pulmonary artery, which you see in pulmonary hypertension. And finally, an RV heave is secondary to right ventricular hypertrophy, while an LV heave is secondary to left ventricular hypertrophy. Move over to another flashcard. An accentuated P2 component of the second heart sound is due to what condition? When you have an accentuated P2, it means this is the particular closure of the pulmonic valve component of the second heart sound. And normally, this is usually not louder than your aortic component. But if you have an accentuated P2, then this is due to pulmonary hypertension. Multiple choice question. The loudest murmur without the thrill is what? Yes, this is the grade 3 murmur. Okay? So you have to remember the classification of your murmurs. It's classified from grade 1 to grade 6. Remember your grade 1, 2, and 3 classified based on the loudness of the murmur, but grades 1, 2, and 3 do not have a thrill. Okay? So any murmur beyond grade 4 and above is always associated with a thrill. So be familiar with the grading of your murmurs. Which of the following would have a positive Carvalho sign? What is Carvalho sign? Okay, this is the sign when you ask the patient to do a deep inspiration or to inspire, and then you appreciate accentuation or increased loudness of the murmur. So is it a mitral stenosis murmur, mitral regurgitation murmur, aortic stenosis, or tricuspid regurgitation murmur? So Carvalho sign, when it's positive, means that the murmur or the lesion is a right-sided lesion, because you will have a positive Carvalho sign in murmurs occurring at the right side, and that's because of physiology. So the answer here is a tricuspid regurgitation murmur, because when you inspire, you increase venous return that goes to the right side of the heart, and naturally increased venous return increases the flow across a particular valve, and that will accentuate murmur caused by a lesion or a valvular lesion on the right side, and that's consistent with the tricuspid regurgitation murmur. Flashcard. How do you accentuate a mitral stenosis murmur? And this is something that is a must-know for you. One of the maneuvers you can do in physical examination, if it's a mitral stenosis or even a mitral regurgitation murmur, you have the patient lie on the left lateral decubitus. So be familiar with the maneuvers that you need to do in order to accentuate specific murmurs of the patient. On the other hand, how do you accentuate an aortic regurgitation murmur? For aortic murmurs, you have the patient sit up and lean forward. And that's the specific maneuver. Now, one other maneuver is to do the Valsalva maneuver. And most murmurs and sounds are usually decreased in intensity during Valsalva maneuver. And this is because of decreased ventricular filling and cardiac output. So all murmurs diminish in intensity during Valsalva maneuver except for two conditions. What are the two conditions? Mitral valve prolapse and hypertrophic obstructive cardiomyopathy. So these are the two specific conditions that increase in intensity and duration during the Valsalva maneuver. Multiple choice. Inspiratory splitting of S2, your second heart sound, is due chiefly to, you see, the decrease in LV volume, earlier timing of A2, a delay in P2, or a prolonged right ventricular ejection. So this is both related to physical examination and physiology. Okay. In fact, all of these answers are correct, but the best answer here is caused by a delay in your P2, and that's the one that causes splitting of the S2. Splitting of the S2 during inspiration, when you have you do deep inspiration, you increase venous return to the heart, and so you increase volume of blood going to the right side of the heart, and this will cause a delay of your pulmonic valve closure, and this is the one that is responsible for the physiologic splitting of S2 during inspiration. Flashcard. What congenital heart disease causes fixed splitting of the second heart sound? This one is a must know. Okay, so this is actually the auscultatory hallmark for ASD, or atrial septal defect, which is the most common congenital heart disease. Flashcard again. What congenital heart disease causes a continuous machinery-like murmur? When you say machinery-like murmur, it's a murmur that occurs both in systole and diastole. So this is the typical murmur for PDA, patent ductus arteriosus. And this one you also encounter in your pediatric cardiology. Let's go over now to physical examination, another flashcard. The ideal blood pressure cuff size should encircle at least how many percent of the arm? This is medicine 1. So the ideal BP cuff size should be 80% of the circumference of the arm. Multiple choice. The diastolic blood pressure measured should be A, B, C, or D. What do you think? So the diastolic blood pressure is actually the pressure at which the brachial pulse disappears on auscultation. Okay, so if you remember the technique of BP measurement, systolic BP is basically the pressure at which the brachial pulse can first be palpated or heard by auscultation, corresponding to your Korotkov phase 1. But it is the disappearance of the pulse on auscultation, corresponding to your phase 4, Korotkov sound, that corresponds to your diastolic blood pressure. Let's move over to hypertension. Now, I know there has been a lot of development as far as hypertension classification is concerned, but if we're still going to use your Harrison, which will be the textbook in your board exam, and hypertension classification is still based on your JNC7, which means stage 1 hypertension is defined as a systolic blood pressure of 140 to 159, or a diastolic blood pressure of 90 to 99. Anything that is 160 systolic and above, or 100 diastolic BP and above, is already stage 2 hypertension. Now, just to compare it with the controversial recent hypertension guidelines published by the American College of Cardiology, which is sets a lower cutoff for blood pressure of 130 to 139 or 80 to 89 diastolic to define stage 1 hypertension. And it defines also 120 to 129 over less than 80 to already be elevated blood pressure. So, but I don't think they will use this in your exam. Just remember, probably the common denominator in these two guidelines is anytime you have a blood pressure of 160 and above systolic or 100 and above diastolic, and both of them classify these as stage 2 hypertension. All right. The condition characterized by both transient and persistent elevations in blood pressure, which is commonly seen when it is taken in the physician's office or hospital, but with normal blood pressure at home, is called white coat hypertension. All right. So let's move over to a review of the pathophysiology of your hypertension. If you recall your physiology, of course, blood pressure is basically the product of your cardiac output times your peripheral resistance, and which means anything that will alter here, increasing your peripheral resistance and maybe cause changes in your cardiac output, can also reflect an increase in your blood pressure or cause hypertension. And if you look at the different factors that can affect the equation when you have excess sodium intake, and that is basically leading to increased fluid volume, when you have renal sodium retention caused by some form of renal parenchymal disease, that can also increase fluid volume, increasing your preload. Any form of stress can affect your sympathetic nervous system, and that also affects the equation, affecting your cardiac output. Of course, equally important is your renin-angiotensin system. Anytime you have a renin-angiotensin excess, it can also affect the equation, mainly causing increased peripheral resistance through your angiotensin, which is a vasoconstrictor. And finally, endothelium-derived factors that can affect the blood vessel, causing vascular remodeling or hypertrophy, can also affect the equation. And so if you take a look at all these different factors, you can actually surmise that there are mainly 4 main pathophysiologic mechanisms in hypertension. The renal mechanism, that is contributed by sodium or sodium excess. Then you have your adrenergic nervous system, which basically reflects your sympathetic nervous system overactivity. Of course, your renin-angiotensin aldosterone system. And finally, your vascular mechanism. And out of these 4 mechanisms, it would be very easy to remember the different drugs that can target hypertension. Diuretics will target the renal aspect or sodium excess. Your beta blockers or alpha channel blockers will come in to take care of your adrenergic nervous system. And of course, your ACE inhibitors and ARBs takes care of your renin-angiotensin aldosterone system, while your vascular mechanism will be targeted by your calcium channel blockers. So basically, these are the main antihypertensive medications, and it's quite easy to remember if you remember it from the mechanistic point of view of hypertension. Multiple choice. Which statements regarding BP are true? Is it related to the risk of cardiovascular disease? Is it positively correlated with the risk of myocardial infarction and heart failure? Or correlated with the risk of stroke? Or all of the above? This is an easy question. I do hope most of the questions in the board exams would be like this. But of course, this is just to emphasize to you that basically high blood pressure contributes to a risk of cardiovascular disease, myocardial infarction, and heart failure, as well as stroke. And in fact, your cardiovascular disease risk has positive correlation with the blood pressure, and as far as increasing risk for myocardial infarction, stroke, and heart failure. And studies have indeed shown that when you control the blood pressure, you decrease these particular endpoints and you improve mortality of the patient, or you improve the outcome of the patient for that matter. So in the evaluation of patients with a documented hypertension, the objectives consist of assessing the lifestyle as well as identification of cardiovascular risk factors that would affect prognosis and guide treatment. You need to reveal identifiable causes of high blood pressure, and most importantly, you need to assess the presence of target organ damage and cardiovascular disease. Let's go now to the different types of hypertension, and they're classified actually based on etiology into primary or essential hypertension, in which there is no identifiable cause, and secondary hypertension, wherein you do have secondary causes of the hypertension. So the most common type of hypertension in the total population is the primary or essential hypertension. What about the most common type of hypertension in the young? It is still primary or essential hypertension. So while secondary hypertension is more common in the young, still majority of the hypertension, the cause is really unknown, and it constitutes 90% of the hypertension, both in the total population and majority of the causes, even in the young. But if your focus would be to look at the different secondary causes of hypertension, there are actually a lot, and this is just one simple mnemonic for you to remember. Just remember chapters corresponding to Cushing syndrome, or even chronic steroid. That's one secondary cause of hypertension. Conn syndrome, or hyperaldosteronism. Coarctation of the aorta, and that's one quite an important cause of secondary hypertension, which is quite simple to detect on physical examination, like taking the blood pressure both in the upper and the lower extremities and seeing a discrepancy. Pheochromocytoma, thyroid and parathyroid disease, of course drug effects, specific drugs like your sympathomimetics, your steroids, your hormones can also cause hypertension, renal disease or kidney problem, and of course sleep apnea. In fact, sleep apnea is one of the important things that you need to rule out when you have a patient who has uncontrolled hypertension. Of course, the target organ damage, they can affect the brain in the form of stroke or transient ischemic attack, retinopathy. As far as the heart is concerned, the target organ damage consists of left ventricular hypertrophy. You can have patients presenting with angina or myocardial infarction. It can lead to heart failure. In the kidney, it causes chronic kidney disease, and of course, in the peripheral blood vessels, a peripheral arterial disease. In fact, hypertension is a known risk factor for atherosclerosis. So the laboratory tests in the evaluation of hypertension, something that should be easy to you. You encounter this in your clerkship and internship. Your routine test consists of the following: a 12-lead ECG, a urinalysis, to take a look at target organ damage, or this is a simple test to assess your kidney function. You need to look at risk factors. That's why you get the blood glucose. You also need a hematocrit, of course, potassium, creatinine. Look at the GFR, lipid profile. Miscellaneous tests consist of your urinary albumin excretion and several other tests. Let's move over to another flashcard. The target BP in hypertension treatment, and this is a must-know for you. Yes, it should be less than 140/90. And just remember, the normal blood pressure is 120/80. And this target, if you look at the algorithm for the treatment of hypertension, consists of the following steps. It's always important to start first with lifestyle modification, looking at weight reduction, dietary modification, change in the lifestyle of the patient. If the patient is not yet at goal blood pressure, and that's the time you start the patient on a medication. And of course, in the guidelines, they look at compelling and without compelling indication. Majority of this recommendation, especially for stage 2 hypertension, would recommend a fixed dose combination. So try to review the different compelling indications for the particular class of drug. So let's review the pharmacological management of hypertension. And this one, just to simplify the different drugs, you memorize the first 5 letters of the alphabet. And this corresponds to the following classes of drugs for hypertension: ACE inhibitors or ARBs, your beta blockers, calcium channel blockers, finally your diuretics, and E corresponds to the others, or etc., your alpha blockers or centrally acting agents. So what are the particular agents for each class? Of course, you have your ACE inhibitors that target your renin-angiotensin-aldosterone system. The beta blockers, which would target the autonomic nervous system, if you still remember the equation in the pathophysiologic mechanism for hypertension. Your calcium channel blocker will target your vascular mechanism. And finally, your diuretics would target your intravascular volume, or the renal or sodium excess mechanism. So be familiar with the different antihypertensive drugs. Of course, your ACE inhibitors are your prils, your enalapril, captopril, ramipril, etc. ARBs are your sartans, losartan, valsartan, telmisartan, and the other sartans. Beta blockers are your olols. Okay, so your metoprolol, atenolol, carvedilol, bisoprolol, propranolol. Calcium channel blockers consist of your dihydropyridine. These are your amlodipine, felodipine, nifedipine. These are your vasodilators. And you do have your non-dihydropyridines consisting of your diltiazem and your verapamil. Finally, diuretics. You have different diuretics in the treatment for hypertension. Your thiazides, your loop diuretics, exemplified by your furosemide, and several other diuretics, and your potassium-sparing diuretics in the form of spironolactone. In the etc. or the other drugs, your clonidine, methyl-dopa, which are your central adrenergic blockers, your hydralazine, minoxidil, one of your old antihypertensives, which are direct vasodilators, and finally your zosines, your prazosin, terazosin, doxazosine, which are your alpha adrenergic blockers. Let's move over to a multiple choice question. The antihypertensive drug of choice for hypertensive patients with a previous myocardial infarction and intermittent anginal episodes is? What would be your answer? Now remember, you have a lot of antihypertensive medications here, but you choose the one that would also target patients with intermittent anginal episodes and those with previous MI, which are compelling indications. And so the answer here would be your beta blocker. Next, the preferred antihypertensive agent for diabetics with nephropathy is what? Yes, that would be your ACE inhibitor. ACE inhibitors have been shown clinically and through different trials to delay the progression of diabetic nephropathy. The preferred antihypertensive agent for diabetics, this time with chronic kidney disease, which would be the antihypertensive drug of choice. It would still be ACE inhibitor. So, especially for diabetics with or without diabetic nephropathy, or even diabetics with chronic kidney disease, ACE inhibitors have in fact been shown beneficial in decreasing progression of the nephropathy and chronic kidney disease, and in fact also preventing nephropathy in those patients who do not yet have the renal problem. The best antihypertensive for a 65-year-old female hypertensive patient with +2 albumin in the urinalysis. So it will still be your ACE inhibitor or your ARB compared to the other medications. One of the following physical examination findings signifies a hypertensive emergency. Which one is the answer? So in here, there's only one finding that would signify a hypertensive emergency, and that would be a papilledema on fundoscopy. So your blood hemorrhages, sustained apical impulse, or an apical holosystolic murmur reflect target organ damage for that matter, but they don't signify hypertensive emergency. Papilledema, on the other hand, is a hypertensive emergency finding. The drug of choice for hypertensive emergency is amlodipine tablet, clonidine tablet sublingual, sublingual felodipine, or IV nicardipine. You encountered this during your clerkship and internship. Of course, the answer is IV nicardipine, and that is the one that is available locally. But if the question is something like this, and you include the following in your choices, if you still remember the textbook, in fact, the drug of choice for hypertensive emergency is actually your intravenous nitroprusside. But unfortunately, it is something that's not available locally in the Philippines. But if you go to the States, then you have the benefit of having nitroprusside. And that is, in fact, the drug of choice for hypertensive emergency. Let's move over now to a flashcard. Which or what antihypertensive drug is preferred for patients with prostatism? These are patients with BPH. You do encounter this, so these are your alpha blockers, your prazosin and your terazosin. And in fact, if your patient has BPH and has concomitant hypertension, then you give prazosin or terazosin. They have an additional benefit of decreasing the size of your prostate gland. And in fact, it is also being used by your urologists for male patients, even those who are non-hypertensive, because of its effect in decreasing the prostate size. What antihypertensive drugs are preferred for pregnant patients? This one you encounter in your OB. Of course, the two preferred antihypertensive agents for preeclampsia are your hydralazine and your methyl dopa. Moving over now to a true or false question. Okay, so thiazide diuretics should be used cautiously in gout or a history of significant hyponatremia. Yes, that would be true, because the side effects of your thiazides would be hyperuricemia and in fact hyponatremia, so you use it with caution. Beta blockers may be given in patients with asthma, reactive airways disease, or even second or third degree AV block. That is false. These are actually contraindications to use your beta blockers. ACE inhibitors and ARBs are contraindicated in pregnant women or those likely to become pregnant. That is true. ACE and ARBs should not be given in pregnant women because of its association with vascular anomalies. ACE should not be used in individuals with a history of angioedema. That is true. That is in fact an absolute contraindication. And finally, aldosterone antagonists and potassium-sparing diuretics can cause hyperkalemia. Yes, that's actually the side effect of these two agents. All right, let's move over now to one of the important target organ damages, and that is ischemic heart disease, coronary artery disease, and atherosclerosis. So what is the initial lesion of atherosclerosis? Is it the foam cell, a fatty streak, atheromatous plaque, or thrombus formation? I think you took this from your pathology. So the initial lesion is a foam cell. And if you take a look at the evolution of atherosclerosis, it actually takes years from the start of the foam cell, which develops into a fatty streak, and later on leading to the atheroma that leads later to plaque rupture and atherothrombosis. So when you talk about atherothrombosis, this is defined as acute thrombosis occurring in the presence of a pre-existing atherosclerotic lesion. And so these events consist of the following: an ischemic stroke, ischemic syndromes of your peripheral arteries. These are your limb ischemia. And of course, the more common acute coronary syndrome, consisting of either unstable angina or myocardial infarction, and in worst cases, your sudden death. So when you have a patient coming in with chest pain that is due to a suspicious coronary artery disease, this chest pain could be either one from an acute coronary syndrome, which is either a ST segment elevation MI, a non-ST elevation MI, or unstable angina, or it could be just what we call as chronic stable angina, as seen in what we call as stable ischemic heart disease. These patients, either they present with a typical substernal chest heaviness, or sometimes chest pressure or squeezing, or a heavy type of pain. Or they could have pain in the jaw, neck, arms, shoulders, or back, or sometimes accompanied by nausea, sweating, or shortness of breath, which are in fact your so-called anginal equivalents. So you need to read on the differences between the manifestations of stable angina, your unstable angina, and acute myocardial infarction, how to differentiate the three based on clinical manifestations. Multiple choice. So if a chest pain or a symptom of dyspnea occurs while doing ordinary physical activity, what would be the functional classification? And this is based on your New York Heart Association. So remember, when you have symptoms during ordinary physical activity, that is a class 2 functional classification. So the key word there is patients in class 1 do not have limitations of physical activity. Ordinary activity does not cause any symptom like fatigue, palpitation. On the other hand, a class 2 functional classification has a symptom during ordinary physical activity, while a less than ordinary physical activity causing symptom equates to a class 3 functional classification. And finally, patients who have symptoms even at rest are classified as class 4. So when you talk about patients coming in with chest pain, you actually have a lot of differential diagnosis. You can have disease entities consisting of a cardiac pathology, vascular pathology, or even a pulmonary cause. So under cardiac, the most common and very important etiologies would be your acute coronary syndrome in coronary artery disease, or stable angina. Other causes are your aortic stenosis, your hypertrophic cardiomyopathy, and pericarditis. For vascular cause, it could be an aortic dissection or a pulmonary embolism, although you can argue pulmonary embolism could be under a pulmonary cause. Well, these are your other pulmonary etiologies of chest pain. So those in red font are the life-threatening causes of acute chest pain. And in fact, in an emergency situation, these are the top 3 etiologies that need to be considered or ruled out. Now, other than cardiac, vascular, and pulmonary, you do have other organ systems that can also contribute to chest pain. Esophageal reflux, or your GERD, in fact, is a very common cause of chest pain. And of course, these are the other gastrointestinal causes. Just read on it. While costochondritis, quite a common cause of chest pain, or a muscular musculoskeletal type of chest pain that you see in young patients and those who do not have any structural heart disease. And of course, anxiety or emotional cause can also be an important differential diagnosis. True or false? Which of the following are clinical features of anginal pain? Brought on by physical or emotional exertion, that is true. Relieved by rest, and that is the character of anginal pain. Usually crushing, squeezing, or constricting in nature, that is also true. Retrosternal, that is in fact the location of angina. Often worse after food or in cold winds, that is one character. And often relieved by nitrates, that is also one description of anginal pain. So the sites of anginal pain most commonly is retrosternal or substernal, but it can also occur in the jaw, in the neck area, in the left upper limbs, left lower limbs, sometimes in the periumbilical area. Which of the following factors will worsen angina? So increase in heart rate, a decrease in contractility, increase in myocardial oxygen supply, or a decrease in vascular resistance of the coronary artery. So you need to understand what particular factors can worsen or contribute to angina. And it's basically speaks of an imbalance between supply and demand. So the answer here is an increase in heart rate, because an increase in heart rate would lead to an imbalance in the supply and demand, such that it will increase demand, and that would worsen angina. So this is the supply and demand balance that contributes to the symptom of angina. So in the supply factor, this is contributed upon by your oxygen carrying capacity, the coronary blood flow, the factors leading to coronary vascular resistance, which consists of these different mechanisms. So anything that will decrease coronary blood flow would decrease supply, and that would worsen angina. On the other hand, demand is contributed upon by the heart rate, the contractility, or the systolic wall tension, which is also affected by the blood pressure. So anything that will increase the heart rate, increase the contractility, or increase the blood pressure would increase demand, and that would affect the oxygen supply and demand and worsen angina. Flashcard. So what would be the first best diagnostic test to request in a patient presenting with angina? This is quite easy, and that's the 12-lead ECG. So another symptom of cardiac disease is shortness of breath or dyspnea. Let's move over to a true or false question. Dyspnea might be an anginal equivalent. Yes, we discussed that. That's true. If it exists with chest pain, it suggests a large myocardial involvement in coronary artery disease. That is true. Can dyspnea be caused by anemia? Yes, of course. In fact, anemia is one of the important causes of heart failure or dyspnea. Does not occur in normal output heart failure. That is false. Okay? So one of the important mechanisms of heart failure is a normal output type of heart failure, which I will discuss later on, and that leads to dyspnea. Dyspnea usually acute in pulmonary embolism, and that is in fact true. That is the character of dyspnea in pulmonary embolism. So this graph is actually in your Harrison's textbook. So when you talk about dyspnea, you divide the etiology, whether it's cardiovascular or respiratory. If we focus on the cardiovascular side, you're talking about heart failure causing dyspnea, and you classify this into either high output, normal output, or a low output cause. The typical prototype heart failure is a low output type of heart failure or congestive heart failure, which you see in your cardiomyopathies as well as in myocardial ischemia. On the other hand, you can also have high output heart failure, which you commonly see in anemia and states like hyperthyroidism or an AV shunt. And finally, a normal output type of heart failure, which is typically exemplified by your diastolic dysfunction. And these are patients who have left ventricular hypertrophy. If you recall, sometimes you encounter hypertensive patients, in fact, who have normal systolic function or normal contractility, but because they have left ventricular hypertrophy, they have what we call as diastolic dysfunction. And that can lead to diastolic heart failure, which is a normal output type of heart failure, and that leads to dyspnea. So try to review also the different respiratory causes of dyspnea, exemplified by, of course, your COPD, your asthma, and other pulmonary causes. Flashcard. So in acute pulmonary edema, cough is associated with production of what characteristic description of the sputum? So you encounter this in your clinics. In pulmonary edema, especially acute pulmonary edema, you usually encounter a frothy, pink sputum, and that typically describes the secretions that you get from heart failure. So of course, heart failure, patient coming in with either heart failure or some of the other end organ damage or myocardial ischemia, you always take a look at the cardiovascular risk factors. And in fact, these are risk factors for atherosclerosis, divided into non-modifiable and your modifiable, consisting of the following. Multiple choice. Which among the following promotes plaque instability? So is it a minimal amount of lipid core, minimal amount of inflammatory cells, a thin layer of fibrous cap, a large layer of smooth muscle cells? This is in fact also stated in your pathology. So the answer here is a thin layer of fibrous cap, which means anytime you have factors or changes that would cause thinning of this fibrous cap, that would make that plaque more vulnerable or more unstable, and that would cause atherothrombosis. So the other factors, of course, when you have a large amount rather than a minimal amount of lipid core, a large amount of inflammation, as well as a small layer of smooth muscle cells, that would make your plaque unstable. So plaque vulnerability, the factors would be the following: a thin fibrous cap, a core size of the atheroma that's greater than 30%, increase in inflammatory cells like your macrophage, as well as the degree of inflammation, both systemic or local. So this would be an example of a coronary artery cross-section with the plaque rupture. You can see the lipid core, the fibrous cap, and the thrombus in the lumen. Another picture of the disrupted plaque with the thrombus there, the thin fibrous cap that has in fact ruptured, and the lipid core. So multiple choice. The primary mechanism involved in acute coronary syndrome. Is it the chronic progressive narrowing of the epicardial coronary arteries, leukocyte recruitment and foam cell formation, plaque rupture and resultant thrombus formation, or an acute embolic occlusion of the epicardial coronary artery? So the answer here is a plaque rupture. That's in fact the pathophysiology of acute coronary syndrome. Chronic progressive narrowing is basically the mechanism in stable ischemic heart disease, while you rarely do have acute embolic occlusion of an epicardial coronary artery. So an acute coronary syndrome that would present with ischemic discomfort would be classified into either of three, and that would be risk stratified based on your electrocardiogram. So you can have a patient with ST segment elevation, myocardial infarction, or a patient who has no ST segment elevation, and that can be classified as either unstable angina or a non-ST segment elevation myocardial infarction, depending on the presence of a biochemical marker, specifically your troponin. So the ST segment elevation the pathology is usually a platelet fibrin thrombus, which causes mostly an occlusive type of lesion, or in other words, total occlusion of the coronary artery. On the other hand, your non-ST segment elevation MI and unstable angina, usually the culprit is a platelet-rich thrombus or a white thrombus, which is in most cases non-occlusive. And this is the reason why the main treatment for ST segment elevation MI consists either of a fibrinolytic that causes early perfusion or early revascularization through percutaneous coronary intervention. So the diagnosis of acute coronary syndrome, you usually need the characteristic triad. From the history, the characteristic chest pain, you need ECG changes, and finally you need cardiac biomarkers, either your troponin or your CKMB. In most literature, in the most guidelines, the recommendation is really to use your troponin. Your ST segment elevation MI on the ECG, of course, you present with significant ST segment elevation of the ECG. So either you have an ST segment elevation like this, or you already have a Q wave, which already reflects an infarct or a necrotic tissue accompanied by ST segment elevation. On the other hand, a non-ST segment elevation MI or unstable angina presents with either ST segment depression or T wave inversion, or in some cases it can present also with a normal ECG. So the gold standard cardiac biomarker for the diagnosis of acute MI is that is your troponin. But the different cardiac biomarkers are either your CKMB and your troponin. But it's the troponin that is more specific and is the gold standard. And you have the cardiac troponin T and your cardiac troponin I. Take note that the importance and the advantage of the troponin, it's not only diagnostic, but it bears a direct relationship with mortality. Hence, it has prognostic value. And this would be the cutoff value of your troponin. You should also remember, though, that sometimes you can have conditions that can cause minor troponin elevations, such as heart failure, myocarditis, conditions like pulmonary embolism, and some of the other false positive causes. Be familiar with the time course of elevations of serum markers after MI. And you know for sure well that your CKMB is one of the earlier cardiac enzymes to go up as early as 4 to 6 hours, but it quickly goes down in a few days, while your troponin I usually also goes up in about 8 to 12 hours with its peak in 24 hours, and it remains elevated for a couple of days. And normally your troponin I stays in the circulation from between 7 to 10 days, while your troponin T stays in the circulation higher for 10 to 14 days. Multiple choice. Which of the following would most likely suggest an acute myocardial infarction? And this one you have to analyze based on the cardiac biomarker, the finding by X-ray, the ECG finding, and the CBC finding. I'll give you a couple of seconds to analyze this question. So the best answer here is letter C. It's your troponin 6.4, which is significantly elevated. You have cardiomegaly by X-ray, and more importantly, you also have a significant ST segment depression on the ECG and leukocytosis on the complete blood count. So a patient who presents with chest pain suggestive of ischemia, of course you get an initial 12-lead ECG, but in the emergency room, you do a lot of these things, check the vital signs, you establish an IV line, you perform a brief targeted history in PE, and try to check contraindications to thrombolysis, and obtain your initial cardiac biomarkers. The emergency treatment, the ER, consists of the following, represented by the acronym MONA. Okay, you can give your morphine for pain relief. If the pain is not relieved by your nitroglycerin, you give your patient oxygen, especially if oxygen saturation is less than 94%, nitroglycerin sublingual or IV, and your aspirin, 160 to 325 milligram to be chewed, ideally. So your 12-lead ECG would be able to risk stratify your acute coronary syndrome into either an ST segment elevation MI, which presents with either ST elevation or a new onset left bundle branch block, or it can present with a high risk unstable angina or non-ST elevation MI, depending on the findings on the ECG, or a low intermediate risk acute coronary syndrome. So the general measures in the management, these patients need to be admitted at a monitored bed, preferably the ICU. You have them on bed rest. You give supplemental oxygen if saturation is less than 94%. And usually the management, to make it simple and easy to remember, you try to memorize the acronym RAPID. R standing for relief of chest pain, followed by antithrombotic therapy, then your pharmacologic agents and interventions, if applicable, and your discharge instructions and planning. So the general measures for STEMI are the following. You need to give morphine and nitrates to relieve the chest pain. Your antithrombotics would be the following, either aspirin, plus either clopidogrel or ticagrelor, or prasugrel, and most of these patients would require also heparin. Pharmacologic agents consist of the following: beta blockers, nitrates, ACE inhibitors or ARBs if you have contraindication to ACE inhibitors, and statins. Then you have interventions, and finally discharge instructions. Taking further focus on the pharmacologic treatment, you need beta blockers to reduce myocardial oxygen demand. You give these patients nitrates. These are meant to increase coronary blood flow as well as to relieve chest pain. ACE inhibitors are ideally given, and this is given to prevent ventricular remodeling. And finally, you give statins regardless of the cholesterol level, because these are meant to stabilize the atherosclerotic plaque. Now, for your interventions, as far as ST segment elevation MI is concerned, the important aspect in the management is timely reperfusion of the infarcted area. And this is either achieved with fibrinolytics or, more ideally, a percutaneous catheter intervention if the hospital facility has a cath lab. Multiple choice. Which one is true regarding the use of beta blockers in acute coronary syndrome? So you have to know what would be the effects of beta blockers and what would be the benefits in the setting of ACS. The answer here is improve myocardial supply demand mismatch by reducing the heart rate. And that in fact is what beta blockers will do. It improves ischemia. It also has some role in the symptomatic relief of chest pain. And in fact, it can sometimes protect you against serious ventricular arrhythmia. Now, you also need to be aware of the contraindications to beta blockers. And of course, anytime you have persistent bradycardia or second or third degree AV block, hypotensive patients, severe heart failure or cardiogenic shock, and of course your asthma or reactive airway disease, you have to avoid use of these beta blockers. So in the management of ST segment elevation MI, the golden period is of course 12 hours from the time of onset of the symptoms. So the reperfusion goals is to achieve a door-to-balloon inflation. That means if you're going to do PCI, your goal is to do it within 90 minutes. On the other hand, you also want to achieve a door-to-needle goal of 30 minutes. That means if you were going to do fibrinolytics, the goal should be to do it within 30 minutes from the time the patient came to the emergency room. So you have several fibrinolytic agents for fibrinolysis of ST elevation MI. Your streptokinase, alteplase, ritaplase, and of course the specific one is your RTPA, your tissue plasminogen activator. These agents are preferred in the following conditions. If you have a patient coming in early, preferably 3 hours or less from symptom onset, or you expect a delay to PCI. It's also preferred if you don't have a cath lab, it's not available, or you expect delay, or you cannot transfer the patient to a hospital with a cath lab facility. Important to remember though that fibrinolytics is only recommended for ST segment elevation MI. It is not recommended for unstable angina and non-ST elevation MI. All right? Multiple choice. What is the definitive treatment of choice for ST segment elevation MI? So the best answer here is timely reperfusion using fibrinolytics or percutaneous coronary intervention. Another multiple choice. Which pharmacologic agent will improve the myocardial oxygen supply-demand relationship, would decrease pain, reduce infarct size, and decrease the incidence of serious ventricular arrhythmias among acute ST segment elevation MI patients? So these agents are actually given for ST segment elevation, but the particular medication that does all this would be your beta blockers. So your beta blockers indeed can improve your oxygen supply-demand relationship. It can decrease pain. It has been shown to reduce infarct size. That's why we give it post-MI. And it has a protective effect against ventricular arrhythmias. In case index chest pain occurred more than 10 days ago, what would be the cardiac enzyme that you would request to verify the presence of acute MI? So we talked about this earlier, and that would be your troponin T, and that's the advantage of your troponin as a biomarker compared to the other biomarkers. It stays in the circulation longer. The golden period of thrombolysis in acute MI is, that's 12 hours. So 12 hours or less, that would be the preferable time for you to do thrombolytic. What is the absolute contraindication to thrombolysis? So this is quite easy. The best answer, of course, is history of cerebrovascular hemorrhage. That is an absolute contraindication. The others below are relative contraindications. Multiple choice. 74-year-old male consulted because of chest heaviness, radiating to the left shoulder after walking 2 blocks, relieved by rest, and he has been having these for the past 2 months. What is the condition of this patient? So this is the characteristic description of a patient who has chronic stable angina. All right? So a typical angina or stable angina, typical chest pain, but it's precipitated by effort, relieved by rest. So in the management of chronic stable angina or stable ischemic heart disease, you have 2 objectives. The first is to improve outcome. That means you want to prolong survival. And the drugs that you can give are aspirin, ACE inhibitor, statins. ACE inhibitor and statins have been proven to prolong or improve outcome in ischemic heart disease patients. You also need revascularization if indicated. So patients who have severe coronary artery disease might warrant revascularization in the form of a bypass surgery or angioplasty. The second objective in the management is to relieve symptoms. And these are the following drugs indicated for that objective: a beta blocker, a calcium channel blocker, or nitrates. You can give sublingual nitrates as needed, or you can maintain the patient on an oral nitrate. Now, there are other second-line agents that are also used for the relief of your stable ischemic heart disease. These are your trimetazidine, your ranolazine, your nicorandil, and your ivabradine. Now, just a particular mention for what we call as Prince-Metals angina, otherwise also known as variant angina. This is an anginal syndrome that might occur usually in young patients. They come to you with a chest pain, but its pathophysiology is different because it's caused by coronary artery spasm. And during the chest pain, on the ECG would show ST segment elevation. They present with anginal pain at rest. Sometimes, in worst cases, they can present with arrhythmia and even heart failure. But the pathophysiology is a coronary artery spasm, and that can cause ischemia of the myocardium. But when you give these patients nitrates, either nitrates or a calcium channel blocker, you relieve the chest pain and you cause resolution of the ST segment elevation. And so this is the typical angina that is caused by coronary artery spasm. That's the key word there. So how do you manage this angina? The treatment is calcium channel blocker, diltiazem, or you can give these patients nitrates. I think a couple of years ago, one of the board exam questions tackled on Prince-Metals angina. Heart failure. Let's move over to heart failure, and it's one of the more important syndromes that you will encounter in cardiology. What is the most common symptom of heart failure? This is quite easy. The answer here is dyspnea. So all of these are actually symptoms, but the most common is your dyspnea. Now, heart failure has a lot of etiologies, but if you're going to simplify the direct causes of heart failure, it could be one that is under myocardial abnormalities, and that's exemplified by your coronary artery disease or your idiopathic dilated cardiomyopathy. This is your typical low output congestive heart failure. It can also be caused by hemodynamic overload, such as in volume overload and in patients who have kidney disease. Okay, and that's caused by overload leading to pulmonary congestion. It can also be caused by ventricular filling abnormalities, and this is the heart failure that you see in hypertensive patients who have left ventricular hypertrophy, and more importantly, patients who have valvular heart disease, your mitral stenosis, aortic stenosis. These are ventricular filling abnormalities that can cause increased pressure in one of a particular chamber that can lead to heart failure. And finally, any change in cardiac rhythm, whether too fast, tachycardia, or too slow, bradycardia, or an irregular heart rhythm like atrial fibrillation, can also directly cause heart failure. Now, in your pathology and in the different chapters in your Harrison, there is a very complicated explanation as to the pathophysiologic mechanism for heart failure. And it all basically boils down to what we call as neurohumoral interplay. And this involves interplay of your sympathetic nervous system, your renin-angiotensin-aldosterone system, of course your vasopressin, your natriuretic peptides, all of these contributing to derangement in your vascular resistance, the blood pressure and cardiac output, also causing changes in your blood volume, venous tone, and venous pressure. And of course, the end result is pulmonary and systemic edema. So just to simplify these pathophysiologic mechanisms, you involve the sympathetic nervous system. There's also involvement of the renin-angiotensin-aldosterone system. There's the element of volume overload, which contributes to your preload aspect of your cardiac output. And there's also the factor of the blood pressure, the vascular resistance that contributes to the afterload of your cardiac output. So knowledge of this pathophysiologic mechanism would make it more simple to remember the treatments that we give for heart failure. To target the sympathetic, these patients need a beta blocker. RAA system, that's why you give ACE inhibitors and aldosterone antagonists like spironolactone. Of course, the volume or the preload is managed by your diuretics. And in some patients, in order to control the vascular resistance, to decrease the afterload, you give this patient a vasodilator. There's also the element of contractility, or what we call the inotropic aspect. In patients who have systolic dysfunction, those coronary artery disease or cardiomyopathic patients who have a low ejection fraction. So the management here sometimes would be to give inotropic agents. Multiple choice. Which among the following is a major criteria for the diagnosis of heart failure? So do remember the Framingham criteria for heart failure. There's a major and a minor. So the major criteria here is your S3 gallop. So try to review your Framingham criteria. Be familiar with the major criteria. The symptoms of PND or orthopnea, distended neck veins, the presence of elevated JVP or hepatojugular reflux, edema, crackles, and of course your S3 gallop. And so you need 2 major or 1 major plus 2 minor criteria to be present concurrently. Which of the following tests would be the most helpful for detecting left ventricular dysfunction and is in fact a marker for heart failure? So if your troponin T is a marker for cardiac injury or ischemia, for heart failure, it would be your B-type natriuretic peptide or your BNP. And this is also requested sometimes, both as a diagnostic and a prognostic marker in heart failure. Let's talk about orthopnea. True regarding orthopnea. I'll give you a couple of seconds to analyze the question. So orthopnea is actually a dyspnea that is due to an increase in hydrostatic pressure in the lungs. And it occurs with the assumption of the supine position. So the answer is B. And it gets relieved immediately on resuming the standing or the reclined or the sitting position. And that's how you differentiate it from P and D. So in general, in heart failure, and especially those who have systolic dysfunction, the left ventricular ejection fraction is a prognostic marker. In such that studies have consistently shown that when you have a lower ejection fraction, this corresponds to a higher mortality in patients, both in ischemic and non-ischemic causes. So heart failure classification can be done in different ways. You can classify it as systolic or a diastolic heart failure, a low output or a high output type of heart failure, or based on the physical findings, right-sided or left-sided type of heart failure. When you talk about systolic heart failure, the prototype would be your coronary artery disease. When you have systolic dysfunction, you have wall motion abnormalities, you thin out left ventricle, decrease in contractility and a low ejection fraction, and that leads to systolic heart failure. On the other hand, a diastolic dysfunction or a diastolic heart failure occurs in patients who have normal ejection fraction, and prototype would be hypertensive patients. In these patients, what you have is a left ventricular hypertrophy, thickening of the left ventricular wall, and this leads to abnormality in the relaxation phase, or that's why it's called the diastolic type of heart failure. But in the clinics, most common really is a combination of the two. You can also classify heart failure into low output versus a high output. The low output is the common ones we see in coronary artery disease and cardiomyopathy. These are patients who have low systolic function. You have wall motion abnormalities and a low ejection fraction. On the other hand, high output heart failure, and as I indicated in one of my earlier slides, you see this in severe anemia, in AV malformations, as well as in hyperthyroidism. You can also differentiate heart failure into right or left-sided based on the manifestation. So right-sided heart failure presents with peripheral edema, signs of hepatosplenomegaly, JVP increase, while a left-sided heart failure presents with pulmonary congestion and is usually due to hemodynamic overload or a weakened left ventricle. So in the treatment for heart failure, you now have two objectives. You want to improve morbidity. That means you want to relieve the dyspnea. You want to relieve symptoms of heart failure. You also want to improve quality of life in this patient. While in the second objective is to improve mortality. You want to prolong survival. And this is done by decreasing the progression of heart failure. And of course, you want to decrease the risk for sudden cardiac death. So in the management of heart failure, this consists of both pharmacologic and non-pharmacologic strategies. Non-pharmacologic consists of limitation of the fluids and sodium. These patients, you also need to have them undergo a lifestyle and risk factor modification. Exercise, cardiac rehabilitation has also been shown to improve outcomes in this patient. And in fact, a multidisciplinary disease management approach is very important. So when we go to the pharmacologic management, and just like the therapeutic strategy for your hypertension, I also represent this with the first four letters of the alphabet. But of course, the letter C stands for congestive heart failure. And since you want to eliminate the symptoms as well as the effects of congestive heart failure, you cross out the letter C. And so now we're just left with A, B, D, and E. So A would stand for ACE inhibitors primarily, or an ARB. Do remember that ARBs are only secondary. You only give it if an ACE inhibitor is contraindicated or the patient does not tolerate the ACE inhibitor. A B would stand for a beta blocker. That would target the sympathetic or adrenergic nervous system. The D would be for diuretics, and that's given to relieve symptoms of congestive heart failure. And as usual, your E would be your etc. Okay, so dilators, nitrates, digitalis, which is an inotropic agent, and your sympathomimetics, your dobutamine, given sometimes short course for heart failure. So take note that calcium channel blockers, or your letter C, are contraindicated in heart failure. So when you talk about the principles of pharmacologic treatment, you all want to target the primary mechanism for heart failure. And so primarily you want to decrease the neurohumoral activity, and that is achieved with your ACE inhibitors and your beta blockers. You also want to decrease the preload. That means you want to decrease volume, and that's why you give your diuretics, primarily your loop diuretics, which is first line for acute heart failure. The others are your thiazides and your spironolactone. Dilators can also be given to decrease preload. You want to decrease venous return, and that can be achieved with your nitrates. Your afterload needs to be reduced in order to optimize the treatment of your heart failure, and that is achieved by your dilators, which is also, of course, your ACE inhibitor and sometimes your hydralazine. And finally, for patients who have systolic heart failure, sometimes we give digitalis, which is an inotropic agent, and in rare cases we give dobutamine, sometimes for cardiogenic shock or other sympathomimetic agent. Take note that among all these agents, only your ACE inhibitors and beta blockers have been proven to decrease mortality. For diuretics, only spironolactone has been also proven to decrease mortality and prolong survival in heart failure patients. Multiple choice. Which of the following heart failure treatments improves survival? So that would be your ACE inhibitor in the form of your captopril. So your diuretics relieve symptoms but does not improve survival. Nitrates likewise improve symptoms but not shown to improve survival. Same thing with your digitalis or digoxin. Which is true regarding the effects of ACE inhibitors? So the answer here is that ACE inhibitors, in fact, can improve survival and also cause improvement in your symptoms. So it's letter D. Which one of the following is considered a contraindication to the use of beta blockers for congestive heart failure? So do remember the contraindication for beta blockers. So the best answer here would be your symptomatic heart block. All right? So mild asthma is not an absolute contraindication, and so are heart failure and a low ejection fraction. Let's go back to a flashcard. What potassium-sparing diuretic can improve survival among heart failure patients? I think I mentioned this earlier. The only diuretic shown to do such would be your spironolactone. Flashcard. Digitalis improves cardiac contractility by blocking what particular channel? So the answer here, if you review your pharmacology, is your sodium-potassium ATPase pump. And that is the mechanism of action of your digoxin. Multiple choice. The concomitant use of spironolactone and an ACE inhibitor in a patient with chronic renal failure may result in elevation of what particular ion? It's quite easy. That's your serum potassium. So that's why you have to be cautious or extra cautious when you combine spironolactone and ACE inhibitor, and especially using it in CKD patients. Okay, last few slides. Flashcard. An opening snap, a diastolic rumbling murmur, and a presystolic accentuation corresponds to what particular lesion? That is your mitral stenosis. So this is your classical murmur of mitral stenosis. An opening snap, a diastolic rumbling murmur with presystolic accentuation. So what would be the most common cause of mitral stenosis in the Philippines? That would be your rheumatic heart disease. Okay, so rheumatic heart disease is actually an organ damage as a sequela of rheumatic fever. And so what would be the etiology of rheumatic fever? So which particular streptococcal infection? So for rheumatic fever, it would be the group A beta hemolytic streptococcal infection of the pharynx. So take note, it has to be the pharynx. The infection of the skin does not lead to rheumatic fever. It leads to acute glomerulonephritis. So it has to be the group A beta hemolytic streptococcal infection of the pharynx. So it is the only streptococcal infection associated with acute rheumatic fever is pharyngitis. And there's a particular genetic susceptibility to this particular agent, which is a major Jones criteria for rheumatic fever. So you need to be familiar with the criteria for RF. So the answer here is your subcutaneous nodules. So the updated Jones criteria consists of the following major manifestations, and you can easily remember that with the acronym CASES. Your carditis, arthritis, your Sydenham's chorea, your erythema marginatum, subcutaneous nodules. Be familiar with the manifestations and presentation of each major criteria. On the other hand, minor criteria consists of your arthralgia, your fever, elevation of our acute phase reactants like your ESR, your C-reactive protein, your prolonged PR interval. Okay, so diagnosis necessitates two major or one major plus two minor manifestations, plus supportive evidence of an antecedent group A streptococcal infection. So either a throat culture, an antigen test, or a rising streptococcal antibody test. The migratory polyarthritis of acute rheumatic fever is what? So the particular characteristic of this major criteria is that it is promptly relieved with aspirin. Yeah? So there's actually a dramatic relief with this particular anti-inflammatory agent. So this polyarthritis occurs in 75%. In fact, it's even more common than your carditis. It involves the larger joints, your ankles, wrists, knees, and elbows. Extremely painful but does not cause any deformities. And it has a dramatic response to your salicylates. So the treatment of an acute rheumatic fever, you need to relieve the symptoms, and that's why you give aspirin. Take note, you give the inflammatory dose of aspirin. In some patients, you need to give prednisones and of course analgesics for pain relief. You need to eradicate the streptococcal infection, and that can be achieved with any of the following antibiotics. Penicillin V, the oral penicillin for 10 days, or a benzathine penicillin injection, single dose, or the alternative, if you have allergy, would be your erythromycin. Now, after the rheumatic fever, you need to give these patients prophylaxis, because you want to prevent further streptococcal infection that can cause further damage to the cardiac valves of the patient. And this can be achieved through maintenance oral penicillin or the erythromycin alternative, or that can be given daily, or you can give your penicillin, benzathine penicillin injection IM every 3 weeks. And this is done at least 10 years since the last episode, or until 40 years of age. And sometimes it can be given lifelong. So the prophylaxis for recurrence of rheumatic fever is, I think I mentioned this in the previous slide. So the answer would be benzathine penicillin IM every 3 to 4 weeks, and that would be the prophylaxis. So rheumatic heart disease is a late sequela of acute rheumatic fever, and usually it occurs 10 to 20 years after the initial attack. It is a major cause of valvular heart disease worldwide, and especially very common in developing countries like the Philippines. RHD can present with either stenotic lesions, commonly involving the mitral and aortic valves, or purely regurgitant lesions, also involving the mitral, aortic, and the tricuspid valve. Or it could be a combination of stenotic and regurgitant lesions. So this is a review. The murmur of mitral stenosis occurs during which phase of the cardiac cycle? This one should be easy for you. So it's a diastole because it's a diastolic rumbling murmur. I think these are the last few slides. Take a moment just to review your advanced cardiac life support knowledge. The most common presenting rhythm in sudden cardiac arrest is it's ventricular fibrillation. So let's go over now to a case. You have a 40-year-old male and is brought to you unconscious with zero vital signs. What would be the next immediate thing to do? Is it defibrillate, get an ECG, do CPR, or intubate the patient? So the best answer would be to perform CPR. So sustained ventricular tachycardia is managed best by which particular option? IV verapamil, IV amiodarone, defibrillation, or you just bless the patient. So when you have stable, sustained ventricular tachycardia, the treatment, the management would be to give the patient an antiarrhythmic in the form of amiodarone. On the other hand, when you have an unstable, sustained ventricular tachycardia, that means your patient has a pulse but is hypotensive or has hemodynamic instability, the management would be, so this time there's no room for medication. These patients need to undergo synchronized cardioversion or synchronized shock. And finally, a pulseless ventricular tachycardia should be managed by what option? So pulseless VT is managed the same as ventricular fibrillation, and it would be managed by defibrillation. So in your ACLS, acute management of your sustained VT, if it's stable VTAC, you have option of giving intravenous medications, preferably your amiodarone or your lidocaine. Procainamide is also an option. If unstable, that means the patient has hypotension, has heart failure, on some other hemodynamic instability. Or if the VTAC is persistent, then you do synchronized cardioversion. And finally, when you have pulseless ventricular tachycardia, the treatment is the same as ventricular fibrillation. So thank you all for bearing with me. I think it was a very long lecture. And let's go back to that particular slide. This is you right now. And I know there's a huge rock for you to still tackle and study the other topics for your board exam. But just try to remember this quote that describes the ordeals of a stone cutter. And just imagine yourself to be one stone cutter. You keep pounding that rock, and subject by subject, topic by topic, and one of these days you're going to master all these topics in time for your board exam, and in time for you to get this particular card with your name there and your particular picture there. So I wish you all luck, and may the force be with you, and I shall pray that you all make it. Good luck, and thank you very much.